think we can probably start now, Arlene. Thank you.
Okay, thanks, Chair. I'd like to remind everyone that the meeting is being recorded and placed on the websites of Dundee City Council and the Health and Social Care Partnership for public viewing. And I'll now take a roll call for the minute. Pat Kilpatrick. Do we have apologies from Pat?
Apologies.
Yeah. Okay. Thanks. Councillor Lynn.
Present.
Councillor Toland.
Yeah, sorry, I'm here.
Thank you. Councillor McHugh.
Present.
Giles McPherson.
Present.
Sam Riddle.
Present.
Diane McCulloch.
Present, Arlene.
Vicky Irons.
Present, Arlene.
Dave Berry, sorry.
Present, Arlene.
David Wilson.
Present, Arlene.
Susie Flower. Susie,
She's on.
I can see her.
Mute.
Yep.
She's on mute.
Okay. I've had apologies from James Cotton. Raymond Marshall. No. Jim McFarlane.
I'm here, Arlene.
Thanks. Christina Cooper.
Present, Arlene.
Liz Goss.
I'm here, but I'm going to have to leave a bit early because I'm going away for a few days and I'm not as organised as I thought I would be. So,
Okay, thanks. Martin Sloan.
Present.
Emma Fletcher.
Present.
David Shaw. And
Arlene,
think
I know that both David and Shona Hyman, who will be joining the meeting for the primary care report, may not be here at the beginning because of an overlap, but he may equally be here and I'm talking on his behalf.
Okay. Councillor Lynn, did you want to come in there?
No, I didn't. I was just testing the raise hands.
Oh.
So some meetings insist that we only use the chat, but I think everyone who attends these meetings is able to use the raise hands function. So I was just testing it, sorry.
Okay, thank you. That concludes the roll call. I'll just
Arlene,
move on
just to mention that's Raymond here now,
Raymond.
sorry.
Yeah, thanks, I got that, thank you. Item 1's apologies, which we've already covered. Item 2 is now Chair's remarks.
Yeah, just a couple of updates really on quite significant events since our last meeting. The Community Wellbeing Centre is now open 24/7 following what they described as a soft launch. There'll be a more formal launch with more publicity at a later stage. So this is really good news. And I'm intending, sorry, someone want to come in there? No? No. I'm going to be visiting there in the near future during the late night, early morning. So I'm looking forward to that, to see how the project's going. Obviously, yesterday saw the release of the Scottish drug death statistics, which showed a further drop in Dundee from 50 to 38, which represents a decrease of 27%. I don't think anyone's going to be rejoicing over 38 deaths. I certainly am not. But my hope is that the improvements in services that we've made over the last few years will continue to bear fruit. And I'm talking about things like the increased support we've been given to those who have a near fatal overdose and the naloxone rollout, because I think our target in terms of drug deaths has to be 0. So that was some good news yesterday. So thanks for that. And we can move on now. Arlene.
Thank you. Oh,
Martin's hands up, sorry.
Just very briefly to follow on from the comments made by Ken regarding the Community Wellbeing Centre. I attended a meeting of the group, the stakeholder group that oversees some of the work that the centre does, and just to say that the opening week numbers were a lot higher than anyone anticipated, and it seems that with the small amount of publicity that's going out about the centre, people are coming to the centre, are making phone calls to the place, and things are looking forward and looking upwards in that respect. And Ken and I will be attending a meeting tomorrow to look at the future naming of the initiative and how that takes it forward.
Thanks for that, Martin. Okay, Arlene, back to you.
Okay, item 2, declaration of interest. Are there any declarations? Donald?
Thanks, Arlene. Yeah, I should probably just declare an interest in relation to item 10, which is the Shakti Outreach Service. My interest being that I'm the chair of Tayside Health Fund, and it has been asked on behalf of NHS Tayside to consider a request from that same group as part of the item 10 narrates. So I think just for the record, I'd like that recorded, but I don't believe it precludes me from discussing or being involved in the decision.
Yep.
Okay, thank you.
Thanks for that, Donald. Duly noted.
That takes us on to item 3, which is membership appointment, and the Integration Board Joint Board is asked to note the position.
Yeah, well, welcome back, Donald. I believe that you're also going to be joining the Performance and Audit Committee. Is that correct?
If the IJB is kind enough to appoint me, yes, I'll be happy to do that.
Yeah, I've got an email asking that you be appointed at today's meeting. So can that be agreed that Donald is welcome back into the fold and also into the pack? Agreed. Thank you.
Thank you.
Yeah, that takes us on to item 4. Item 4A is the minute of the previous meeting held on the 21st of June, and it's submitted for approval.
Okay, I'll just run through this briefly. First page, page number 2, page number 3, 4, 5, 6. That's the final page. Can these be agreed as a true representation of what occurred at the previous meeting? Yep, thank you.
Okay, that takes us on to item 4B, which is the action tracker, and it's submitted for noting and updating.
Yep, this continues to shrink meeting by meeting, which is good. So there's less outstanding actions. Any comments on the action tracker? Questions? Dorothy?
Yes, thanks, Ken. Just on number 1, considering that this is now 8 months overdue, according to the action tracker, can we give a time frame for submission to the IJB, please?
Yep, fair point.
Thank you, Chair. I'll come in on this. I'm happy to go and have another conversation, Dorothy, and ensure we've got proper time framing for the next meeting if we can't get it to the next meeting. I know that the team have been very highly kind of involved in other areas of work recently, and that's effectively why we've not managed to get to that stage yet, but we'll ensure that that's updated for the next meeting.
Thank you.
Donald?
Thanks, Chair. I had a similar point on item 3 on the list around the Dundee Alcohol and Drugs Partnership Framework and Delivery Plan. Again, due date to be arranged once initial planning complete. I think, again, as with 1, it would be helpful to have a date against that in the action tracker.
Certainly, Chair, I'm happy to come back in again for this one. Just to update you, Donald, that we've got a site visit this week with property. We've had a little bit of toing and froing in relation to just being really clear about our processes around any move around Constitution House, just because the complexity of the number of different organisations and processes that we need to work through. So we have a site visit with one of our property asset colleagues from NHS Tayside. at Wallace Town on Thursday, in which we hope to get a better understanding of what our options are in relation to that service and what work might need to be done in order to move in. So following that, we'll have a better understanding of where we are and what our ask might be in relation to future planning. So once we've got that done, we should be in a better position to come back.
So we'll be having an off-table discussion then. The chair, vice chair and relevant officers. That'll be after you. You, yep. Okay, next item, please.
Item 5, Annual Performance Report 2022-23. You're asked to agree the recommendations.
Okay, it's a very, very lengthy document. Who would like to speak to this, please?
Me, please, Ken.
Thank you, Lindsay.
Thank you. So the 5 editions of the 22-23 APR are for noting by the IJB. These were approved and published on the 28th of July to meet the statutory deadline of 4 months after the end of the reporting period, which was the 31st of July. So the APR is required to contain data containing the National Health and Wellbeing Indicators. That's one of our requirements of the legislation. And we receive this from Public Health Scotland, as do all other partnerships. But for some of the indicators, it isn't possible for Public Health Scotland to provide financial year 22-23 year data in time for the statutory deadline. They would provide calendar year data, so 2022 data, and publish financial year 22-23 data at a later date. So as you'll see from the recommendations, we will update all of the versions of the APR with financial year data as soon as this is made available to us. Additionally, the APR it comprises 5 editions, and it was intended that these editions be published throughout the financial year. However, in practice, that wasn't possible. We hadn't intended to submit them all to you at once as a bundle. 2 reasons for that. The first being resource pressures within the team, but also we found when speaking with operational colleagues that actually they need time to accrue content. So case studies, survey findings, evidence of improvement activities, etc. So it's not feasible to have that sort of early on in the financial year. It really has to come towards the end of the financial year. The 5 APR editions were produced using a digital formatting tool called Sway. The links to the Sway documents are in the papers. This allows the reports to be interactive and more engaging than a traditional report, we felt. But we understand that not everybody has internet access. So we also extracted the 5 reports into a Word document to allow the reports to be printed and sent to anyone without internet access. And also that makes it possible to convert the text into accessible formats if we're requested to do so. So regarding the 5 APR editions, the first one is a report which covers all of the governance requirements of the legislation: resources, complaints, inspections, performance against the National Health and Wellbeing Indicators. So again, these are statutory requirements. It was brought to our attention that the wording of Indicator 19 wasn't clear enough, and we have actually corrected this on all published versions, just not in the papers that you're looking at, but it has been corrected on everything published on the website. The additional 4 APRs, they aim to provide operational evidence against the 4 strategic priorities within the commissioning plan: health inequalities, early intervention and prevention, localities and engaging with communities, and models of support pathways of care. So in these editions, we have reported biggest achievements, and within that, we've tried to give as much evidence as possible: narrative, operational description, survey results, quote, images, etc. And using the Sway version makes it, brings these to life a lot more than if we had copied and pasted into a Word document. We also report the greatest challenges over the last 12 months, and also where we need to improve. And where we need to improve is very much linked to the Strategic Commissioning Plan, which has recently been published. So happy to take any questions.
Yeah, I've just clicked on the link there to one of the SWAY documents, and it really brings it to life, and it's easy to read and understand. Dorothy, please. Oh no, sorry, I beg your pardon. It's Sam. I'm looking.
Put my hand.
It's
Not yet.
Sam. It's on my screen. Sam's just underneath you. It's Sam's hands. It's up.
Yeah, thanks, Chair. Yeah, it's a very impressive document, and obviously a lot of work goes into producing this. I wonder what feedback do you get, if any, on it from government or from members of the public who've read it? Does anybody come back and ever give you feedback as to how well we're doing or otherwise?
Well, we certainly ask for feedback before we publish. We go through a consultation feedback process with staff. In terms of feedback from the Scottish Government, we don't receive a great deal, and I don't think I've ever been contacted from members of the public following publication for further information.
Okay, thank you.
Next up is Liz Goss.
Okay, I just had a few questions. One was, it was about the percentage of the population that self-identified as being disabled, being 7% in one part of the document, and then later on it was 8.3%, and I would imagine that's because it's collected differently. But I know there's it's not always easy for people to self-identify as being disabled or not disabled. I think it's sometimes a bit woolly. And I know within my own community, some people will absolutely identify as being disabled, some won't, and everything in between. So it's just where these different figures came from and just why that difference.
Absolutely happy to answer that. So the first part of the document, we're referring to the entire population who completed the census. That figure comes from the census. The second reference to disability is for the working age population only. So it's not the entire population.
Yeah, that's lovely. Thank you. I had one or two other things. Is that okay? Just to
yeah, of course, yes.
Indicator 1, the percentage of adults able to look after their own health. So I wondered what the plans were to improve that situation, and how to give people the tools so that they can look after their own health better. And what else was it? Yeah, just generally, what are the plans to make that indicator better than it currently is? And how involved are people in actually providing input in terms of what might be done differently?
I see Catherine Sharp's hands just come up. Are you wanting to respond to this, Catherine?
If that's okay.
Yes.
So I think, Liz, the most recent strategic framework has one of the 6 priorities is around self-care, because I think there's recognition that we need a more focus and investment and maybe a broader range of choice for people around how they engage with self-care, whether that's people who maybe have an existing long-term condition or a kind of crisis in relation to their health, or about more that kind of prevention and early intervention end of it. So there's quite a lot of detail, which we'll not go through just now, in the strategy around the kind of shifts we would like to see around that and supporting people to manage and look after their own health, and support communities to be able to do that collectively together as well. But I can send you the kind of the link and the kind of specific pointers to where that is, and if there's any other questions from there, I'm happy to pick them up with you outside the meeting if that's okay.
Yeah, that would be grand. I suppose personally I'm involved with a couple of charities and they're very supportive. They provide lots of information. There's helplines, there's patient stories, there's all sorts of information that's really helpful in terms of managing your condition and being more actively involved and in directing what your care will be, being in partnership with clinicians. So I think there's lots of good examples out there, and it's just how we can make it better for everyone.
Yeah.
Thank you.
Okay, next up is Donald McPherson.
Thanks, Chair. And thanks, Lindsay, for bringing this forward. I mean, I'm coming to it a little cold, obviously, but I thought it was a really good document. And I think the use of SWAY, and that's the first time I've seen it, really brings it to life and makes it much more accessible. So well done on that. I mean, realistically, it's still a 140-page document when you look at it. And Yeah, I doubt many people in Dundee are going to actually sit down and read it through end to end, and more likely, I and others will skim and dip into it in areas of interest, and I think Sway really helps that. I think my only observation around the content of it, that there's a piece around the national KPIs, understandably, but then we've got lots of local strategies and plans, but it was quite difficult to see headline outcomes, what were our intended outcomes for the year, what were our actual outcomes. And I think if there's one thing that each of the 5 sections would benefit from, it's all just a single page up front that highlights some of the key intended and actual outcomes over the year. So that's something I'd encourage you to think about for the coming year. The only other question I had, and there's a piece around, it's at page 31 of the document, where it talks about good practice for social care providers around how they treat their staff. And I think I'm pleased to see that. My question was, what are we doing to monitor actual practice against that code, and what are we doing about it where we feel providers aren't matching up to the code?
Yep, I'll bring in Jenny to answer this point, because her hand just went up, and I'm assuming that's why. Oh, well, I don't think.
Sorry, Ken, I just wonder if Jenny's having some.
I think she must be having some
problems there. I mean, I hope I'm going to be able to answer or say what Jenny's waited to say in terms of Donald's response there. Yeah, I mean, we have the IJB did agree the sort of fair work approach to our contracted services, particularly the care at home side of things. We have quite a well-established kind of contract monitoring kind of process involved with each of the providers. There's kind of regular meetings held with care providers and that, and there's also the opportunity for staff to kind of feedback if there are kind of practices that aren't kind of as they are anticipated to be. So, there are always kind of routes for any sort of issues to be raised with us. If they're not doing that, we do have kind of given the contracts in place, there are contractual ways we can kind of then kind of rectify any issues with providers in that regard. So if they're not kind of if they're breaking the contract in effect, then there are things that we can do around that. We do have kind of quite a lot of kind of discussions with providers around the expectations of the contract, etc. So hopefully we've got quite a robust kind of process in place to make sure that's that any issues are kind of brought to our attention.
Yeah, thanks, Dave. If I can just come back on that, I mean, is there any plan for us as an IJB to get visibility of how well providers are doing? Because some sort of periodic assessment would perhaps be helpful, because it's a really important issue.
Yeah, I mean, we'll have to kind of think about that as a management team around what might be best for you as an IJB to kind of see around that. I mean, it would probably be more exception reporting than anything else on that, if there were any particular concerns. I see Diane's got her hand up
Diane,
as well. Are you coming in on that, Diane?
Yeah, I'm conscious. I think Jenny's stuck at the moment. So a couple of things, Donald. First of all, we have a regular reporting into our clinical care and professional governance forum, which includes any information both in relation to commission services, but also internal services around direct provision. We also provide an annual report on grades each year, which would most likely go to Performance and Audit Committee. So we report via our clinical care and professional governance reports, but also we have an annual report on grading, which we provide. So we already do those things, but happy to have a further discussion if there's more that you feel needs to be taking place.
Okay. Thanks. Next up is Dorothy.
Thanks, Ken. I enjoyed reading these reports. They're well written and easy to understand, and I think the content's just about right. In terms of the National Indicators update on page 37 of the bundle, I've had significant correspondence with Lindsay about understanding what this report's actually telling me, and I'm really grateful for her efforts, including an email at 7:30 this morning. You know, that's above and beyond what is to be expected. So thank you, Lindsay. And just as an aside there, I would like to suggest that consideration of some kind of briefing for IJB members on understanding the numbers and the charts and the data and the statistics that we're being given, because I have had some difficulty. The first thing that struck me about this single page, A4 page performance report was there's an awful lot of red on it, and of course that jumps right out at you. And I wondered, I mean, I was specifically inquiring about indicator 19, the number of days people aged 75 plus spend in hospital when they're ready to be discharged per 1,000 population. I couldn't get my head around that, but Lindsay's trying to help me with that, and I will do further work on it. But I looked at the actual figures behind these red thumbs down, and they're quite stark. And if you compare the numbers for 21-22 with 17-18, it's more than double. The rate is more than double. Now, although I'm not fully understanding what that number means, I see the difference between, you know, how it's grown over time, and that really concerns me. I wondered, are there improvement plans in place as standard when all these red thumbs downs appear? What is the process? But again, thank you, Lindsay. You've been so helpful.
You're welcome.
I'm going to bring in Jenny because she's using Catherine's camera now. Go ahead, Jenny.
Yeah, I'm having some major technical difficulties. Thank you, Chair. Yeah, so the good news is that position's looking a lot better now, and obviously you'll be aware that in that year we were coming out of the pandemic, and the way that we experienced that was a huge surge in demand. And it's taken us a bit of time to reset to those levels of demand, but everything that we're doing is now starting to bear fruit. Our unmet need hours in terms of social care is coming down. Our discharge without delays work starting to show through. So we've seen those numbers come down to the point that we've actually only got one reportable delay in 9 wells today, and have had for the past couple of weeks. Huge improvement work going into that. A lot of the fair work that you've heard about, the work that Lynn Mormon's presented around delayed discharge, things like that. So, yep.
You happy with that, Dorothy?
Yeah, that's good to hear. My question was, so there will be improvement plans then in place when these red thumbs downs are flagged?
Yes.
Yes, for all of these indicators. Yeah.
Yeah, we use that to generate our improvement work.
Okay, thank you. And I'd like the IJB to consider whether we would want to have a briefing session on more fully understanding the data that's presented to us in reports like this, because it's important. I really struggled with the wording around a few of them, and I would like some help and some support in fully understanding what I'm looking at.
Yeah, I think that's absolutely right, Dorothy, because all of us, well, other than officers, obviously, come to the IJB as laypersons. And as you say, some of the reports are very technical and hard to understand. So yeah, I'd certainly be in favour of that. We could get something organised, a guide to the more technical aspects of reports and graphs and etc.
Thank you.
Dave's nodding his head, so I think he's going to be organising that. And next up is Raymond Marshall.
Thanks, Ken. I was really just in response to something that Dave said around people being able to raise concerns, and I think looking at the paper, some of those were around service provision, but I was more interested in, I think you made a comment, Dave, around staff being able to raise concerns around employment. So I would be interested to understand how that works and how safe and secure that raising is for staff. As we know, that it can be quite daunting to raise any concerns around employment. But then I'm just wanting some clarity as well, because my understanding is a previous paper was seen around fair work was around the principles around that, and then hopefully having a plan to embed that clearly within our commissioning. So therefore, and I suppose the question was, how was that progressing? But more interested in how staff safely raise concerns around their employment, given a lot of the different employers that are employed under that are used under the IJB. Thanks, Chair.
You're going to come back on that, Lindsay?
Yeah, no, thanks for that.
Okay.
Yeah, I mean, within the sort of contractual frameworks that providers do have obligations around their staff. There is kind of engagement with or kind of opportunities, obviously through trade unions where they exist. In terms of, we're kind of trying to make sure that trade unions are available to organisations as well. So there's kind of opportunities through that route. And I mean, we have had kind of quite a few examples in the past of kind of staff members coming directly to and external organisations coming directly to us with concerns around their whether it's around their pay. So, for instance, a lot when there was the implementation of the kind of Scottish living wage. And the kind of the move to kind of increase the particular kind of wage levels, there's a kind of lot of a kind of opportunity for starting, and kind of there were some kind of people that come back to kind of highlight where they hadn't been paid those particular kind of levels that we were paying the providers to provide, but they hadn't kind of passed that on. So we're able to kind of pick that up kind of immediately with the providers and kind of ensure that those sort of kind of payments were made on that side of things. In relation to the kind of fair work side of things, I mean, we have. I mean, there's obviously there's the kind of the national approach to that, as well as our sort of kind of more local implementation of that. Particularly the kind of care at home side of things, Jenny and her team are kind of constantly engaged with providers around that. We're monitoring how that's kind of working at the moment, both in terms of service delivery and in terms of impact on things like kind of staff recruitment, etc. Because it is quite it is a big investment from us in terms of the IJB in that side of things. So so again, I can't remember what we actually said at the Fair Work report. I need to kind of go back and look at the recommendations. I can't remember if we did say we would kind of come back with a kind of update report, but I think it's probably kind of wise for us to do that anyway, just to kind of see how that's progressing. So I don't know if Jenny's still, if there's anything else Jenny wants to add, if she's still around, or if it's Catherine's.
Let me see.
Can't see
still
anything
online,
anyway,
so I think she would have indicated by now if she
Yeah.
did want to say something. Donald's up next.
Yeah, thanks. I was just going to come in relation to Raymond's point. One of the other hats, which I wear, of course, is NHS Tayside's whistleblowing champion. And it's maybe worth just making the point that the ability to raise whistleblowing concerns extends beyond NHS employees to anyone who's employed providing healthcare services within Tayside, and that's something where we do seek assurance from contractors, that they have arrangements in place. But certainly if you're employed by a contractor providing healthcare services, you can access whistleblowing. Now, because obviously the Health and Social Care Partnership is providing a combination of healthcare and social care services, the social care side would need to flow through Dundee City Council's whistleblowing arrangements. But I think my understanding is that Dundee has similar provisions in place. So yeah, just I did want to make the point that just because you're not an NHS employee, you can still raise a concern if it relates to whistleblowing services that you see in your employment.
I wonder, how is that publicised then? How do people know about it?
It should be communicated through the IJB, and one of the things that certainly I've been looking for assurance on is that we are communicating it, and not just through emails, but we need to recognise a lot of our people don't sit in front of a computer all day or indeed any day. So there were posters circulated across the system that I hope are visible. We also have the website. There's a section on the website dedicated to whistleblowing, so people can go there. But anything that we can do, and hence I raised the point today, anything we can do to make staff, wherever they're working, aware of that is to be welcomed.
Absolutely, totally agree. Jenny has reappeared under her own name this time, so hopefully her
Well,
camera's
hopefully,
working.
but I'm not absolutely, no, the camera is definitely not working.
Oh,
But I
that's
think it
fine,
might
that's
make
fine.
the microphone work if I don't put the camera on. There's a number of different routes, and there was some specific work done when we were embedding the process by Carol Brunton, and who's our independent sector lead, and David Phillips, just to survey staff and take a sense check on that. But I wonder if we'll maybe take it on as an action specifically around raising awareness of the whistleblowing one. But we have routes for people to raise concerns via contractual processes. There's also routes via the care inspectorate when they're inspecting. So there's a number of routes that people can raise concerns. We're trying to kind of embed more an approach where people have access to things like unions as well. So Raymond and Jim have been invited along to providers forums to try and do that, but I would say it's an ongoing bit of work to try and embed this.
Yeah, it's so important that people are able to raise concerns. I remember I'm having a flashback here at a previous employment when I was almost physically assaulted by an employer with whom I raised a concern, but that was a while ago now. So
I seriously hope it's moved on since those days.
yeah, I seriously hope it has too. That was in the 90s. I don't see any other hands. Yes, I do. Lindsay's hand's back up again. Maybe you just want to round up here, Lindsay.
Yeah, absolutely. Thank you all very much for your comments. They're all very helpful, and where are there any which we will are relevant to further iterations of the APRs, we'll certainly take these on board. I just had a couple of points about Councillor McHugh's comments. I just wanted to go back, if that's okay. Very happy to support any committee members with further understanding of the national indicators. No problem at all. Regarding National Indicator 19, I just had just to supplement what Jenny had already said. I did look back at the benchmarking with other partnerships, and although our rate has increased over the years, we're still performing favourably when compared with other partnerships in Scotland. We're still well below the Scotland average, and we're not even at the halfway point in terms of our performance. So just to give assurance about that. Councillor McHugh asked about how we prepare action improvement plans where there's poor performance. So we do have our 4 quarterly performance reports, which go to the Performance and Audit Committee for scrutiny. And where there is any particularly poor performance, we do have a data group which looks at in-depth indicators on a more in-depth level. So, for instance, we have for quite a while now been focusing on readmissions, and there will be a paper at the next Performance and Audit Committee about readmissions. So when operational managers want to improve the indicators, they really need to understand the data, need assurance that the data is correct, that the codings have been applied correctly, and it's after we have further interrogated the data that we can then pass on to operational managers to look at the actual operational improvements. So we're about there with my example of readmissions. We're also looking at the falls indicators as well. There's a falls data group which is being chaired by Matthew. So it was just to give that assurance regarding how we are interrogating the data for improvement, which can assist operational managers and operational teams to make the improvements there as well.
Thanks for that. I think it's time to move on from the annual performance report. We are asked to approve the recommendations from 2.1 to 2.3. Note the content of the report. Note that it was published, and also to instruct the Chief Officer to update the annual performance report with financial year 2022-23 data for all national health and wellbeing indicators as soon as data is made available by Public Health Scotland. Is this agreed? Thank you.
Okay, that takes us on to item 6, Performance and Audit Committee Annual Report 2022-23, and this is for noting.
Yeah, it's quite a short report, just shows the topics that we've considered throughout the year, and a handy checklist on the second page. Any questions or comments? No, Dave, yeah.
Yeah, no, thanks, Ken. No, just to say that this is the first time that we've actually produced a report. It was following a recommendation from internal audit, which in the kind of annual internal kind of audit overview. So it really kind of almost like kind of closes that wee bit of a gap in terms of our governance, given that the Performance and Audit Committee is a subcommittee of the IJB. So we've not, I mean, other than the Chair's assurance report, which obviously comes through to each IJB following a Performance and Audit Committee, there's not any sort of kind of formal kind of reporting back to the IJB from the Performance and Audit Committee. So this will become an annual feature in our governance arrangements for the future. So if there's any kind of comments on content, we can take that kind of off table as well. If there's things that people think are missing or they'd want to see in future, but that's the kind of first annual report.
Thanks for that, Dave. That report is for noting. So can we move on to the next item, please?
Item 7, Alcohol and Drug Partnership Annual Report, and this is for approval.
Thank you. I'd imagine Diane's going to speak to this. Yep.
Yeah, certainly. Thank you. So this is the annual survey that the Scottish Government do every year and ask ADP leads to complete. It really just provides information to Scottish Government in relation to the national mission and allows them to track performance over a period of time, but it's very much baseline information. So it's seeking what current services do you have in place and what is it that you're providing. They reviewed the documentation this year in relation to recognising that there are other ways that information is being provided into the Scottish Government, including MAT standards, etc. Did acknowledge there might be some double reporting, but wanted to kind of tighten it up in terms of the national mission. They also this year, and I think probably reflecting the fact that the MAT standards work is signed off by the Health and Social Care Partnership, who has to take a leadership role in that. This year they've actually asked that IJBs are also cited on this, and that it's signed off by the IJB as well as the Alcohol and Drug Partnership. The timescales in terms of returning was quite tricky and didn't allow us to bring it to a previous IJB, so it meant that in relation to a final document going to Scottish Government, we've been delayed in doing that. But what we were able to do is to provide a draft version to the Scottish Government in June within the timescales, because the ADP were able to sign that off. So it's coming here for your consideration and approval. If approved, we will send that on to the Scottish Government as our final version. And I think the only thing to say other than above that is that we have already been in discussion with the Scottish Government in relation to the report, just clarifying any issues that they wanted to do so. So I won't go into any more than that, but happy to answer any questions.
Anyone have any questions? Donald.
Yeah, thanks, Chair. Thanks, Dan. I must put in, when I saw ADP annual report on the agenda, this wasn't really what I was expecting, because it's very much a sort of tick box report. And to be frank, I'm not sure what value we add as an IJB by giving our approval to something that's already gone into Scottish Government. But I think, well, but we will do go through the process. But I think what it brought home for me is the question: do we receive, what would be a proper annual report from the Alcohol and Drug Partnership, and in a single place, and tracking against the published framework? Because I think clearly it would be useful to see how we're progressing each year with what's clearly still a very challenging issue for Dundee and indeed the rest of Scotland.
Yeah, I think you're absolutely right, because it isn't an annual report as such. It's not. Yeah, Diane.
And so I'm going to let Catherine come in a second, but I think actually we were missing the word annual survey report on this. And I must admit, when I saw it myself, I realised that had been omitted from the title, and so therefore not put through in terms of the agenda. But I know what Catherine's going to, so I'm going to allow Catherine to come in just now, and I can come in with any other comments.
Thanks, Diane. So just to reassure people that there will be, this is an administrative return that's required from all these ADPs by the Scottish Government, and we recognise it isn't, it serves a purpose, but it's not necessarily fit for purpose as a public-facing annual report, Donald. So we are currently working on our integrated Protecting People annual report that we hope to publish at the end of October. So that will cover not just the ADP, but also adult protection, violence against women and child protection as a single integrated public-facing report. But it's also probably worth mentioning that when the COG meet, so the Dundee Chief Officers Group for Public Protection meet later this week, they will get an update report from the ADP around the development of their performance framework, because that is the mechanism through which we will begin reporting both to bodies like the IJB, but also to the public around the achievement of both the actions in the delivery plan, but also the impact that's having across some key performance indicators. So the ADP, are just in the final stages of that, and Chief Officers will be discussing that tomorrow morning, and Diane and a few others will be present to support them to consider that too. So we're getting to the stage where we're going to be able to do those things, but you're absolutely right, that is not the purpose of the paper that you've got in front of you today.
So
Thanks, Catherine.
Just a question of a missing word then. Liz, can I bring you in?
I suppose it was just a comment. When I first read this, I had questions in relation to some of the gaps, but it's been explained that this isn't really a performance paper. It's more just this is where we are right now, and the background sits somewhere else. And I suppose it was the background that interested me more than this paper, in all honesty, in terms of, what plans are in place to actually fill some of the gaps in terms of representation or how complaints and feedback are used to make service improvements. But I understand this isn't the paper for that, and it'll be interesting to see that in the future. That was all.
Chair, happy to come in if that's okay.
Yeah, sure.
Let's conscious that there'll be quite a lot of information coming into the post, and Donald as well, relatively new. We're happy to kind of have a separate meeting off table and bring people up to speed with what we've done and where we are. So really no problem if folk would like that.
Yeah, absolutely. Yeah. So we are asked to approve the content of the reporting survey, and also note that the Dundee ADP has already approved the submission and the draft report was submitted to the Scottish Government on the 26th of June. So can we retrospectively approve this? Thank you.
That takes us on to item 8, delivery of primary care improvement plan annual update. You're asked to agree the recommendations.
I think, yeah, Shona's here. I don't know if David's coming as well, is he? Not? Yeah, there he is. Yeah, so fire away.
If it's okay, we were going to do a little bit of a presentation this morning, just to give sort of a bit of a wider update, not just around the primary care improvement plan, but some of the wider context which we thought might be helpful. So we obviously did the IJB development event last August, and we presented the primary care improvement plan for last year in October, and also the premises plan that we had in October. But we felt that some of the data that David's been looking at in particular would potentially be helpful for the board to be aware of. So I'm just going to put this on to slideshow if that's okay, and I'll share my slides if that's okay. And David and I will do a little bit of a double act if we can. And I now can't see anybody to share, so sorry, I'll just have to undo that. If I move this over to that side, sorry. Okay, can you see that? Yeah, okay.
Yeah.
So David's going to start if that's okay.
Okay, thanks very much, Shona. So I guess this is just a bit of a background to what's happening in the general practice element in primary care. Just to start with, the link to the places that I've taken my information I've put in the chat just now. That takes you to a Public Health Scotland website. There are a variety of different data sets that are there. Some of this data is taken from Scottish data and then translated to Dundee. We don't have Dundee specific information for things like hold time equivalent. Some of this data is relatively new, so there's information that's now being collected over the course of the last 5-6 years on GP activity level. If people want to sort of do a bit of digging, then that's where to go to. So I guess one of the major concerns that the patients have is being able to access their general practice when they require it. Part of what the Primary Care Improvement Fund has been about is to try to make sure that there are additional options, which are sometimes better options for patients. So we've got direct access into physio. We've got a team that helps to ensure that there is consistency in the care received by patients in nursing homes. We have key link workers who can deliver the full set of social interventions that perhaps are more powerful than a prescription might be. And an element of what we've been doing in Dundee is to try and get the right care available as rapidly as possible. Sometimes involves disintermediating the GP from that, sometimes not. Now, part of the reason why we're doing that is because we think it's a good thing to do. And part of the reason why we're doing it is to try and make practices more sustainable. The first few of these charts really is a little bit about the sustainability part. So in Dundee, we currently have 22 practices. We've unfortunately lost Invergowrie earlier this year, and we lost Dry Hill last year, and a few years back we lost Dobswell, and we're working with another 4 or 5 practices that currently have closed lists just now. So there are ongoing sustainability issues, and I guess these charts are an attempt to try and explain what is going on. So one of the things that's going on is that we get fewer partners out there. the traditional thing when I was a lad, you were going to be a full-time GP and you were going to work 9 sessions in practice. So that was 4.5 days a week or 45 hours a week, maybe a little bit of out of hours on top of that, just if you're feeling a bit bored. And nowadays, that's not necessarily what GPs want to do, and they certainly don't want to take on the risk that being a partner is. Now, you say, what kind of risk is that? Well, if you're a partner, then you're responsible for the building, and that may be several £1 million worth of either capital or lease commitments over a 20-year period. And if you can't find someone to take on the lease and your practice implodes, you are still responsible to the landlord for that. You're also responsible for paying your staff and for their redundancy if you can't afford to pay them. And you're obviously also responsible for the smooth running of your practice. So if there are difficulties, then it's you that carries the can. So for some reason, this is less appealing to younger doctors, and there has been a move away from that partnership model. And the risk for the IJB is that without partners, you start to lose practices. Ultimately, someone needs to be the employer of a salaried doctor, and that will either be NHS Tayside or it will be a partner GP. So we need GPs to be able to take risk, or otherwise we start running practices. And with the best will in the world, the NHS is not great at running practices, which is what you would expect, because I guess we don't have a personal investment in making sure that the practice works, or contractual things of an unpleasant nature happen to you. So as I said, it would be ideal if we could retain a contractor model. It seems to work the best. Now, if we can move on to the next slide. So this is taken from Public Health Scotland's activity data. We've got a time series that goes from 2018-19 up to 22-23. So this is pre-pandemic through recovery. And as you can see, that there's been a steady increase in activity. I think this is the GP count section if you want to look into it yourself. And that shows that there were, I think, about 620,000 contacts in 2018-19, and now we're up to about 680,000. That's based on a 3% increase in our overall Dundee population over that time period. So we've got activity outstripping population growth. Lots of different reasons for that. Some of that relates to an increase in morbidity. Some of it relates to difficulties in other aspects of the health and social care system. If you're on a 18-month waiting list, there's every chance you may decompensate and attend with your practice on several occasions over that time period. When you might not need to do so. We have an aging population. We have difficulties sometimes accessing other services, so sometimes people go in through their general practitioner. So lots of different reasons why demand is increasing. But as you can see, it dropped during the pandemic, it has increased past that, and we have now overcome that. Now, beyond that, we've got estimates on whole-time equivalent GPs. This is imputed from a headcount figure, which again you'll find, I think, in the GP workforce paper that's also on Public Health Scotland. We know how many GPs there are in Dundee. We know how many whole-time equivalents you get out of each GP over time. So they've got a time period. Shows that progressively there are less whole-time equivalents per head count. And the reason for that is both male and female GPs are working slightly fewer hours. I think we're down to almost a 40-hour week now. The gender balance changing means that you need more in total in order to have a equivalent whole-time equivalent output. So you need to train more folk to stand still. We've also had issues with older doctors like myself working longer hours because that's how we grew up, and younger doctors choosing to work more sensibly. and restricting to, as I said, 45 hours a week instead of doing the out of hours on top. So what you get when you take the activity data in the first chart and then you divide it by the whole time equivalent data while accounting for the headcount changes is this chart here, which shows that the activity per whole time GP has gone from around about 5,700, dipped down to about 5,100, and it's now up at 6,600. And if we move on to the next slide, you can see that just showing a year by year change in activity. So it's about a 10% drop during the pandemic period. That's largely because folk were a bit scared of, I think, accessing doctors because you might catch COVID off them. So I think all parts of the service, accident, emergency, general practice, secondary care, all noted similar dips in activity. There's been a strong and consistent growth in activity year by year since then. If you move on to the next slide, what you'll see when it comes up, there you go, is an activity index. So if we take 100 as being 2018-19 as being the base year, if you convert those annual changes into what would your average doctor working 40 hours a week, which is 8 clinical sessions, what would they actually be seeing? Well, they would have seen a dip in their activity, followed by a sustained increase, so that they're now doing 15% more than they were pre-pandemic. And I think that's resulted in certainly practices having to adapt what they do to try and manage that additional workload. If you move on to the next slide. So in terms of what does that adaptation look like? I think the slide's not moving, but never mind. That adaptation involves, I guess, trying to get more out of the practice team. So we're investing in our nursing colleagues. Certainly, advanced nurse practitioners are increasing in numbers. We're reviewing what practice nurses do, so that we can put more chronic disease management in through that. We are changing our clinic structure. We are trying to attract new, younger doctors still in training into practices. We are changing the consulting model with patients. So some practices have experimented with continuing a triage system in order to gain access. Others have gone back to face-to-face. Some places they've got a mixed model. Now, it's important for us as a partnership to know where practices are struggling. And what we've been doing within Tayside is we have been trialing a sustainability matrix. This is a list of 27 different questions that all practices are asked to answer. And it's a data set that is common across Tayside, so we can compare ourselves with other partnerships. Practices compare themselves with other practices. Now, we do need to treat this with a degree of respect, because some of that data is, I guess, very personal to practices. So kind of reports that you see here, where they're color-coded, give you an impression without actually saying which practice is which. We know that at management level, but we don't particularly want to be putting out there that practice A is in trouble or practice B is doing just fine, as that in itself can cause instability. But if you know where the trouble is and you know what the circumstances are behind the trouble, then you can maybe do something about it. I think there's a saying that all happy families are similar, but all unhappy families are different, and very much practices all will have their own sources of unhappiness. And this sustainability matrix helps us to get a bit more granular. We can say, here, what we really need to do is to sort out a premises solution for this practice. They have got weaknesses in their nursing team. this practice has got a group of doctors all approaching retirement simultaneously. So it allows us to see what it is that can be done. And certainly this is for practices so that they can also see what it is that they have to do. Ultimately, if you don't know that you've got a problem, then you have a problem. And I think the matrix helps practices to do that. Now, what we have here is how that looks across Dundee. So you can see we've got our 22 different practices all on a little bar chart, and we've applied a number from the sustainability matrix to that. So you can see that you've got some practices that have got significant issues. They're on the left-hand side of the graph. You've got ones that are really doing not too badly, and they're on the right-hand side of the graph. So this, again, allows some estimate of the amount of concurrent difficulty that we've got. Do you want to move on to the next one? Okay, now this is data that comes from the Health and Care Experience Survey. That's on a different website. That's a data set that's been going on for, getting on for about 20 years now. Every 2 years, several hundred patients in each practice get a questionnaire sent out to them, and they're asked to rate certain aspects of their health and care experience, which include things like GP access. Now, what we've done in Dundee primarily is to focus on urgent care, so that if you need a doctor and you phone a doctor, you can get to speak to one. We do reasonably well at that. Certainly, these scores tend to be better than elsewhere in Scotland. And the reason why we invest in that model in practice is because the needs of patients who come from more deprived communities are usually more urgent. So you'll find that there are different weightings in practices that look after affluent populations, where there's more of a premium on knowing exactly when you can speak to the doctor rather than speaking to the doctor that day. I think if we move on to the next slide, you'll see that perhaps we do less well with the advanced booking. So if you want an appointment 3 weeks next Tuesday so that you can get in between that urgent work meeting and the Scout club that you're taking Junior to, then you will be less satisfied in Dundee than you would be in other parts of Scotland. And it is difficult balancing these different things. And as I said, different places have got different balances. So we are aware there's a weakness now. This data is somewhat dated. I think there's a new survey that will go out this autumn, which will be published next year, which I think will probably give us our best view of how things are in the post-pandemic. So I think we shall be moving on to change. Now, I think, Shona, that is the end of my set of slides. Do you want to click on? Yep. So do you want to do the how it's all looking in the future and the next bits, or?
Yeah, apologies. There seems to be a bit of a lag with the slides not changing. So I don't know if you can see the slide. This is about GP partners who are planning retirement in the next 2 years. So that was part of the sustainability survey, because obviously workforce planning longer term is a key element of any workforce, including in general practice and primary care teams. And there's been 2 surveys. They've not been exactly the same, but this is one of the areas of data that can be compared. So you'll see that according to that data, there are 27 practices who have at least one or more GPs retiring in the next 2 years. There are some practices where there's almost all of the GP population who will retire in that time phase, who are over 55. So we've got some really significant challenges coming on top of those that we already have, given the issues that we've got with recruitment, which is the next slide. So we've asked practices as well about vacant posts, and this has been really, really helpful data to get, because practices do report recently there's sort of to NHS Scotland, but not necessarily locally. So this is the first time we've had workforce data for practices at a local level. So again, an increasing number of practices who are not filling their vacant posts in the last 6 months. Now that's not unique to GP workforce, but obviously given the context that David's given, then that's really significant. And actually the discussions that we've had in Dundee, this is Tayside data, but we've probably got more than that now. So this was done in January. We are planning to repeat this again later in the year. So we think that the numbers will have worsened since then, given some of the wider context we're aware of with practice discussions. So I guess the key thing for the board members is, okay, what are we doing to try to change this and improve this? And obviously we've heard this is, I think, the 5th year now where we've come with the primary care improvement plan, and the workforce we've described, we've focused on GPs, but actually they're just one example of the workforce. We've got significant challenges across all of the workforce in all parts of the system. David and I this is our 4th meeting together this morning, actually. So one of the meetings was with a practice. We've really challenged with their workforce, particularly around admin. They've managed to stabilise their clinical capacity, but they've got really significant challenges with their admin and management capacity now, and that impacts across the workforce. So the way primary care teams are integrated, any change in one bit of the system impacts more broadly, and particularly in practice, GPs are having to pick up additional roles while they support their admin team. The other meeting that we've both just come from is around pharmacy, and we'll come back to pharmacy later because again they've got really core challenges, and again it's well covered in the media. All elements of the pharmacy workforce in primary care, hospital and secondary care and in community are really challenged, and that's a national issue, as all of these are. So we're not unique in this, but how can we try to change that? The other big issue for us is premises around leases and loans. I'm not going to go into much detail on that because we did cover that in fairly detail when we were here in October. We've mentioned before about the Career Start programme, trying to support new GPs who've just qualified for the first 2 years. Again, we've done really well in Tayside with this programme, but David was updating this morning that we've, I think, previously filled a number of posts, but I think we're down to maybe 3 or 4 people who've applied and likely to progress with that programme before. I think in previous years we've had between 7 and 12 people, so we're just not attracting people to come into the posts, even these posts which are relatively supported and integrated and got really good opportunities. They appear to be attractive posts. David was saying one of the people is probably going to Australia rather than staying here. So we're looking to recruit people from abroad, but equally we have staff who are moving to abroad as well. We're developing our advanced nurse practitioners and other advanced practice roles, but again, in terms of the Primary Care Improvement Fund, we've probably at the ceiling of what we've got currently allocated. What else can we do around that? And pharmacy are really being challenged. They've been really creative in terms of the new roles that they've created, and you'll see that described in the plan. But across all of those elements, we're still continuing to struggle. We want to create roles that people do, and the culture within practices and how communication works in practices is really key to that. And having different career programmes to support people is, I think, really important. And again, we've got colleagues who are doing a huge amount of work, particularly around our nursing workforce internally. We're looking at how can we do that to integrate posts into general practice, as well as staff that we employ directly within NHS. And there's, I think, still significant work that we can do in that context. In relation to the plan itself, you'll see the table in the paper. I put that onto a slide. I thought it was helpful just to see that we are making a shift now. So you can see that the lines are increasing. So we're spending more money. I guess the question is that money that we're spending actually making a difference to people? So we really struggled at the beginning to get things moving, to build the momentum. That momentum's increasing. We're increasingly getting staff into post. Does it feel any different? We did a survey with general practice staff, with our employed teams and with patients at the beginning of the year, and I've put up some of the quotes just to sort of highlight the challenges that we've got. We got a lot of positive feedback. I think once people engage with the new services, they're seen positively, and most people have a positive experience. So the ability for people to be able to choose something that's really local. So if you work in King's Cross like I do, I don't need to go to my practice at Hillbank. I've got a care and treatment centre much closer to me if I need my bloods done. So that's really convenient for me. We've got an element of convenience, which is a particular issue for us in Dundee because of the way people are spread across the city and don't necessarily live near the practice. But equally, we've got quite a lot of feedback, and we had this fairly significantly when Julia did all the work on the premises strategy. The role that receptionists now have is increasingly complex in terms of getting information and getting people to the right bit of the system, and it does put people off. So sometimes our phone systems aren't particularly accessible, but also it's that questioning when people get to speak to somebody. So how the practice manage that and how we're giving them support to do that's really key, and we're looking at some work in the coming year that hopefully will help with some of that. There's still, I think, particularly for older people, a real perception that they treat receptionists as if they're different, but we're all bound by the same confidentiality rules. So again, our communication and the challenges around that are something that we need to really see how we can make a difference with that this year. Do GPs themselves feel any different? I think they recognise the value of the new teams and that people are getting positive care and often, as David's highlighted, better care than they may do from the GP. They're seeing somebody with specialist skills, but they're not feeling the impact. So those charts that David demonstrated with the increasing demand means that despite the number of people who are now being seen elsewhere in the system, it doesn't feel any better if you're a GP on a day-to-day basis, because that increasing demand is kind of outstripping the increasing delivery that we're providing through our wider services. Contractually, we've got 3 core areas we have to legally deliver. There will be directions coming into law in the coming year that mean that we need to deliver these. There will be transitional payments for practices if we're not. The vaccinations, as everybody will be aware, is pretty much moved both for children and for adults now to central team delivery. We're continuing to work with the teams around that and evolve that and work through some teething problems. But overall, that work's moved from practices. Pharmacy, we've described already. There are challenges around the pharmacy team. They are almost moving backwards at the moment. So they're really struggling to maintain the number of posts that they have, even although they've got a hugely diverse skill mix in their teams at all levels. They're really struggling with recruitment. Care and treatment services, which is probably the thing you'd see from the numbers people access most, are but just about there. We've moved most things. Some practices, because of convenience, are still doing some of the work internally, and we're not quite at the stage of being able to meet the demand for all urgent bloods. But we're getting there. With some premises challenges for some of that. So until recently, we were really struggling with finding space for some of the staff that we're employing. We think we've got rooms for them at the moment, but again, our premises strategy is really core to supporting this delivery. What else could we do? So we've obviously been challenging ourselves around, we need to keep developing this. We need to be creative. How can we do more? Practices are really positive about the urgent care home team. So if you're in a care home, you're much more likely to be seen by an advanced nurse practitioner or somebody from that team than a GP now. And that's been hugely valuable, the continuity of care, the wider holistic approach that's taken, and then the communication back to the practice is dealt with by that team, and that's been hugely helpful. But we haven't managed to create capacity to do any of the home visiting, despite some of the tested change that we've done previously. The issue we have is how do we get something that we can scale up given the limited resource that we now have available to us, if any. So we've been having ongoing discussions with the team around how do we do this. We're looking at our district nursing workforce as they develop, so the transforming roles within district nursing will potentially feed into this. There are roles developing that will support some of this, but again, we'll still have a gap that we think we could potentially meet if we had the appropriate resource to develop that workforce further. leases we need to accelerate, and there's a range of discussions that are happening in relation to that. The public awareness, I've highlighted already, that people just not understanding the changes, and it's difficult. We've had some discussions with Scottish Government in terms of the national messaging around this. That we've done local campaigns. NHS Tayside Comms team have helped in terms of some of the social media. We've printed leaflets and things, but actually it's probably by experiencing the service and word of mouth that people are starting to hear about it. But I think there are some other ways that we need to consider how we start to change that, and it's making it people recognise the added value of the changes. The reception role, again, we're hoping to invest some funding this year in developing not just the reception role, but the context that they sit within, the risks that that brings potentially, in terms of ensuring people get to the right place at the first point of contact. And then some additional funding for career start and advanced practice training. We've got some short-term funding, but we need to try to secure funding to ensure that we can continue these in the longer term. The wider context of primary care, so not just general practice, but the other primary care contractors is really important as well. So optometry, dentistry and community pharmacy deliver huge amounts of primary care. We tend to focus on GPs. It's the service that most of us contact most often, but the primary care strategy is developing around the wider primary care contractor stream, and we're hoping that we'll be doing some engagement both around the Tayside approach to this and also our local approach coming into the autumn and early winter time. And from that we're starting to look at, well, what are the local deliverables beyond the primary care improvement plan, which focuses on particular aspects that we need to be progressing. We absolutely need to make sure that we're using the resource that we have as efficiently as we can. Are we maximising the impact that the services can have? We need to do more evaluation around that and get into some of the detail that sits underneath. So the focus has very much been on getting things up and running. It's taken us some time to do that, but we need to continue to ensure that we're looking at the quality improvement around that. Communication I've described. The premises plan that we brought in October, we've still got some actions that we really need to try to move forward. We've recently a new post in the property team within the NHS Tayside, which we're hoping will help with some of this. And obviously we're looking at that at a Dundee level as well. Additional funding might help with some of the issues, particularly around the advanced practice workforce and also the Career Start programme that we want to ensure are sustainable longer term, and the wider resilience and sustainability work. How do we really support practices on a day-to-day basis when they're having these challenges of their workforce, and our flexibility to be able to support that's really important as well. And we struggle to be able to recruit a workforce to help with that. But again, as we build the teams, hopefully we can get a much more dynamic and fluid system that will sort of break down some of the barriers as to where you're employed, and it's much more around ensuring that we provide the appropriate care at the right time for people. I realise that I've not really covered the paper, but hopefully that draws out some of the key points that are helpful for people, and absolutely happy to take questions.
Yeah, that's very helpful. Thanks for that presentation. It was very, very detailed, and I think primary care is something that a lot of people are anxious about at the moment, because it's a lot of the news reports are about the sort of things that you highlighted in the report there and the presentation about the number of GPs who are going to be retiring soon, etc., etc. But it's also really encouraging the amount of work that's going on to try and safeguard primary care in Dundee for now and for the future, and the kind of thinking outside the box that goes on, you know, trying to get people the care they need. And it may not necessarily have to be the GP who they see to provide that. So I have to see, do we have any questions here? Anyone want to ask anything about the presentation or the paper? Sam?
Thanks, Shona. Thanks, David. As you know, I was involved in general practice for many, many years in Dundee, and it's reassuring in some cases to see how much work has been done and continues to be done, and all the things are moving in the right direction. Just a few things spring to mind. Has the number of complaints about general practices, has that increased as a result of what's been going on recently. And that's one thing. The premises, just another. I know the Director of Finance was saying that he was involved, and hopefully there's going to be progress with that, because, as you said, without premises or decent premises, and I saw that firsthand, obviously at Westgate, that it makes it so difficult for things to change. And the reception staff, obviously, as you say, the impression the public have of reception staff is that they're there as an obstacle, and anything you can do to improve that image has. I don't know how it's done, but it has to be, and the government have a big part to play here, because throughout the take, contact your general practice, and then the practice staff get vilified for asking the most basic questions, but people don't understand what their role is. And I was told on a number of occasions, I'll not tell a receptionist, I'll only speak to a GP, which makes it so difficult. So that the other thing. And I suppose the other thing that recently that I've noticed, dental, which obviously is, I don't know what the situation is in Dundee, but dental, trying to find a dental practice now is almost impossible. I don't know what progress has been made with Dundee with that. So those were just a few thoughts I had initially. I'll let others come in.
Sure. Sam, thanks very much for those questions and for the points that you've made. We do track complaints, and they are an element within the sustainability matrix. So we've got a sort of complaints per 1,000 patients as being one of the things. I think there's a gradual increase over time. Complaints, my view in them is they're useful because you find out where your system isn't working. So you want complaints so that you can work out how to make it better. Yeah. Obviously, you get complaints you can do stuff about, and you've got complaints you can't do stuff about. But as I said, it's a thing that we track, and we do have the ability to pick up practices where there is variation and explore the reasons for that. So that's there. I think your points about care navigation are very well made. If you've got so much of GP time, then you want to make sure that it's being used in the most effective way that it can be. And absolutely, the receptionist is the person who navigates you to the right place for you. If she probably knows what services the practice can offer better than you do. And if your correct destination is the GP, then the GP will be able to get prepared for that consultation if there is some detail on the screen already. So if you're a GP case, if the GP is mentally in the box for helping you best, that's good. And if you're not a GP case, then she can get you to the right spot so that your journey is quicker and surer. Is that okay?
Yeah, thank you. Yeah, thank you.
David, Sam's other questions were around premises. So I think probably, David, you're probably best placed, but there have been more recently, since the Director of Finance's commitment to work more closely on premises, there's been a number of fairly positive meetings. Again, it's about the pace of some of that. I think that's the challenge for all of us. And you're absolutely right about dental. There are a huge number of dentists who are withdrawing from delivering NHS care. As you've said, it's well covered in the media. There's a lot of publicity about it, and dental care is absolutely critical for our population in Dundee. It's maybe something that we need to consider bringing something to the IJB about the other contractors, rather than just focusing on GPs. And hopefully the primary care strategy will maybe be the opportunity to do that, and we will bring that document to the IJB. But it's a real challenge for us. The deprivation means that we often have poorer oral health in Dundee, so access to NHS dentists is a really important issue.
Absolutely, yeah. Just going back on that one, the IJB's responsibility really is to work with practices to identify where premises are needed, to support the adoption of leases and loans where that is in the interests of the patients of Dundee, and where premises are needing to be adapted or new premises are needed, to make some recommendation as to what that alternative provision should be. And I think as a health and social care partnership, we are getting closer to the position that we can make those sorts of recommendations. So that's a lot of the work that Shona's referred to. Dentistry, we have invested in the public dental service, which is the kind of fallback if you can't get private dentistry and you can't get registered. Then there is the public dental service. They have a limited amount of capacity. They have recruited some additional capacity there, but it is concerning. And absolutely, poor oral health is positively associated with deprivation. So I think there are actions taking place in that area, but absolutely there are weaknesses in it. And that the new dental contract does not transform things to the degree that I see an imminent route through.
No. Okay, thank you both. Donald.
Thanks, Ken. Thanks, David and Shona, for the presentation. I had 3 points, if I may, 2 from the presentation and 1 from the paper itself. The first one for David, I think, from early on in the slides, you showed a chart of the number of salaried and partner GPs. And the partner GP number was declining over time, and that doesn't surprise me for all the reasons you went into. The salaried GP number had been rising steadily, but then there's a downturn in the last year, and I think the question for me, is that a blip or is it part of a new trend, which I think might itself be worrying? I don't know if you want to take that one, then I'll come back with my other questions. Is that best, Chair?
Yeah, I can only hold so much of my brain at one time, as we've already demonstrated with my answer to Sam. So I don't think it's a new trend. I think it's more likely to be a blip. That may be more hope than experience, but we continue to see trainee numbers holding up well. We've got more and more practices becoming training practices as a response to not being able to recruit. The idea is that if you train a GP in your practice, then through a process of Stockholm syndrome, they'll decide that you're a reasonable place to work, and they'll maybe sign on after. These things, they're all kind of lumpy. I think I'd need another year of data suggesting that we weren't getting more salaried GPs in. It's just they don't work as many sessions as partners, and they aren't carrying risk the way that partners do, but they are absolutely much better than not having anyone. So I want to see more salaried.
Good. Okay, no, thanks, David. And if I can continue, Shona, you towards the end of your presentation, you spoke about the evolving primary care strategy and the developing Dundee GP strategy, and I think my concern there was I would really like to see a clear timeline on when these will be in place, because I think it's going to be difficult to set direction without those, and I think that seemed to me to then flow through into the direction within the paper itself, where, and I know we're still all getting to grips and getting a hang of direction between ourselves and authorities, but it was quite difficult for me when I looked at the actions to be delivered within the direction. I've probably all been on these appraisal courses talking about SMART objectives, specific, measurable, realistic, time bound, and a lot of the actions felt to me quite vague, and I wondered whether, clearly the direction as it stands is what I'm sure we'll approve, but do we not need to be focusing more on specific actions targeted towards outcomes that are set out in the strategy? So there's a bit of a missing link there for me.
I think it's an important point, Donald, around the timescales. We'd been it's about trying to dovetail and ensure that the local Dundee delivery is dovetailing into the overall Tayside strategy and recognising the wider contractors as well. And as you've highlighted, the sort of the complexity of that system is not straightforward to do that. Take on board your points about sort of timescales within the primary care improvement plan, and I think maybe that reflects my approach to things rather than anything else. I think it's just we're very clear on timescales to start with, and they've slipped, particularly because of COVID. And I think I've just become a bit averse to timescales for some of the actions. I think we're demonstrating that they are moving, and that sort of there's a bit of an exponential increase. But the strategies coming are much broader than that. So I think what we see will be much wider than sort of the 7 work streams that we've got within the primary care improvement plan. So I think when we get to the local delivery plan that sits underneath that in terms of actions, I think the strategy will be set fairly high level in terms of its strategic intentions, and it's then the local delivery plan sitting underneath that. So yeah, absolutely, we've not really started doing a huge amount of work on the delivery plan till we've sort of got the overall strategy agreed, but I think your point's important and we need to take that on board.
Okay, last but not least is Dorothy.
Thank you. I've got a couple of comments on the presentation and then a question on the actual report. I find that presentation very useful. Thank you for bringing it. I just wanted to comment anecdotally. I'm involved with the Dundee Pensioners Forum, and what I hear from older people in terms of GP services is 2 areas that concern older people are the phone systems and the explanation to the receptionist. Now you've covered both of those in your presentation, and I think it's all part of it's about communication. You know, older people like things to be done the way they used to be done, and we need to change that and change their expectations into the real world. I know you'll be making efforts to do that. They don't understand the changes, a lot of older people. They don't see why things could change. They're so frustrated hanging on for 25 minutes to try and get through to their GP that they end up hanging up. And that, of course, has implications for unmet needs. So it's a serious issue. That's just my anecdotal comments about GP services, but that was a very useful presentation. I have a couple of questions, Ken, on the report relating to risk and integrated impact assessments. Can I just do these now?
Yep.
In terms of risk, some of us had a briefing yesterday on risk appetite. Dave Berry, thank you. Don't know whether I've got my head around it yet, but I'm trying. And one of the things that I noticed in this report, that there were 5 risks outlined, and all of them were sitting at severe. And all of them said it's recommended that this risk is accepted. So my question is it ever recommended that we don't accept risk? And what would happen then?
Dave?
Yeah, thanks for that, Dorothy. And yeah, in terms of the inherent risk, so the kind of what the kind of risk is started with, that's usually the case. It's usually kind of a higher risk. I suppose the key thing for the board is actually around the mitigating actions, which will kind of start to reduce that level of risk, and that's really, I suppose, is what the board is kind of really looking to. So so this is the risk as it is now, but what we're setting out in the report, and particularly if you look at this one, because of the investment plan around primary care, and a lot of the issues that kind of David and Shona have introduced today and kind of reflected back at us, how much of that investment plan is going to start to mitigate some of those risks. So it's the kind of residual and the sort of planned risk, or kind of the residual risk is actually where we think we'll get to kind of next, and then where we really want to be. So it's those elements there. If you've been presented with a number of risks and there was no mitigating actions, then that's a kind of very different story. So we would not be kind of saying no. And back to that risk appetite session yesterday, it may be that, okay, we've already said that we're willing to accept a level of risk on some of our activities, but in the absence of that, if we're looking at no mitigating actions and actually, you know, it's an extreme risk, then we wouldn't be approving what it is we're trying to do, if you see what I mean. So so it is kind of, so you're right in terms of the way with if you kind of link back to the risk appetite, on the absence of risk appetite, that's where we're not quite kind of connecting that all through just now. So so yeah, inherent risk is usually, well, should be much higher than it is after the mitigating actions.
Okay, thank you. I've got a question on the integrated impact assessment, if I may, please. Page 219, I think, of the report. Yes. Throughout this impact assessment, there are, under a lot of areas, they're coded as no known potential impact, when actually the impact is not known for a lot of these. And I don't understand why no known potential impact results in a no impact scoring. It should be a not known scoring, should it not?
Dave? Anyone?
So I didn't kind of like.
Yeah, I understand what
Dorothy's
saying. So the categories under are positive, no impact, negative, and not known. And
Yes.
what we've said is no known potential impact. So yeah, we've made an assessment. It's interesting because I had to put no impact in. And it was changed to no known potential impact by one of my colleagues who's a bit more experienced in this. So yeah, I think we were thinking if we don't know that there's any, then we're thinking there's none. But I guess it's, how do you ever have a degree of certainty that something might not arise? So yeah, probably the wording was used is confusing. So yeah. I'm not sure. I think we think there isn't an impact, but I guess until you start to change things, how do you know? So yeah, there's a tension around the categories, isn't there?
Yeah. If you think there isn't an impact, then I think you need to evidence that there's no impact. So it's really not known. These should have been scored not known. That's my view anyway.
Yeah, can I bring in David Wilson, please?
Thanks, Ken. I was just going to, just for a comment in terms of my role as a working GP in the city. I mean, I've got 25 plus years of working as a Dundee GP ahead of me, so I've got a vested interest in how this all goes. And as David pointed out, there's reasons that people take up partnerships or not, and I'm currently not in a partnership but in a clinical lead role because of a lot of the issues that kind of David highlighted. There's no doubt that the work that the Primary Care Improvement Group, led by David and Shona, is doing is making a positive impact on the ground. It's something that we're discussing regularly in teams as clusters. The sustainability survey that's come out is allowed to highlight and action issues that practice both individually and at cluster level can action and improve on. We've got the enhanced care team and the community care and treatment service who come along to those cluster meetings when they need to allow practices to help model what that care looks like and how we can best help practices. And there's no doubt that future work on nursing roles, career start funding and things, as well as care navigation at a more national level and kind of how that's communicated is going to be pretty imperative to things. So hopefully it provides a bit of reassurance as much as anything.
Thanks for that, David. I don't see any other hands. I'm still thinking about this whole issue about receptionists, because that is a really wide perception that they're not medical experts. I don't want to tell them my what's wrong with me, because it wouldn't be confidential. But, you know, when people phone up NHS 24, they're effectively talking to the same sort of person. They're telling them, and they don't think twice about that. And Martin's put something in the comments about maybe change the title of the receptionist to something that's, I don't know, medical advisor stroke receptionist. And we'd have to have some sort of campaign, because I really think this is quite a logjam in primary care. You know, and that was quite an extreme slide you showed, like someone's likened them to the Gestapo. So that was just my thought, David.
So the name that's being popularised at the moment is Care Navigator. So they navigate.
So that has been looked at. Good.
Yeah. There's a Scottish campaign behind this, and there are posters, but you may not necessarily have seen all of those. We do, as part of the Primary Care Improvement Fund, some patient research to see what it is that the people say about the services that they receive, and we're using that as part of a comms strategy to try and get some of these messages across. The changes that you're seeing in primary care, I think, are to such a degree that it takes a lot of investment over a lot of time to actually get that comms to change very long-held views as to how practices should work. So we identified this as absolutely an area where we have to take the population with us, and we need to be better at doing that job. So we're working on it. Not quite there yet.
Yeah, that's interesting. Good to hear. So are we happy to agree the recommendations in the report from 2.1 to 2.6? I'll highlight the ones that aren't just for noting. Approve the proposed actions for 23-24 and notes the proposed allocation of funding as detailed in section 3. 2.4 instructs the Chief Officer to issue directions to NHS Tayside to implement the specific actions relevant to them, and Appendix 1. And finally, 2.6 instructs the Chief Officer to provide a further report on progress made against delivering the Dundee Primary Care Improvement Plan to a future IJB. Can we agree that? Thank you. Now, it's at this point where I would definitely have a break, but we're very, very far on in the agenda. There's only like a couple of items left. I don't know, do people want a 10-minute break or do they want to press on? But I think probably in the best interest of everyone, we should just have that 10-minute break, actually, because it's been an hour and 3/4. And then I'll see you at 11:55. Thank you. And Arlene, would you like to introduce the next item, please?
Yep, thank you. It's item 9, financial monitoring position as at June 2023, and it's for noting.
Dave.
Yeah, I'll pass on to Christine. She's going to lead us through this one.
Okay, great.
Thanks.
Hi, Christine.
Hi, everyone. Yeah, so this is our standard paper that we bring to all of the IJB meetings. Obviously, the first report for the new financial year 23-24. And these figures are based on our actual position up to the end of June for the first 3 months of the year, plus the 9 months projected up until the end of March. The forecast for this coming financial year is indicating a projected overspend of 2,852,000 for 23-24. And commentary about the key points in the report and details, the breakdown of the figures are noted in Appendix 1 and 2 and throughout the report. It is acknowledged this is obviously quite a swing from our underspending positions that we've had over the last couple of financial years, but it should also be acknowledged that this is not actually unexpected and is actually currently in line with our 23-24 financial plan, where we were indicating an anticipated shortfall of up to about £3 million in this current financial year, with that gap being funded from reserves that we've set aside for that. In general, most of the sort of general comments are a lot of the underspending areas are continuing to be the result of vacancies that we've got across a lot of teams. Excuse me. A lot of that's due to the recruitment and retention challenges that we're experiencing. Well, some of the overspending areas are often due to the premium costs of agency or locum staff or other supplementary staffing costs, where we obviously need to maintain safe staffing levels in certain aspects of it, and that can only often be covered by agency or bringing in additional overtime or part-time additional hours. And there's also an impact of under recovery of income due to lower activity levels in some service areas. Couple of points just worth highlighting through the reports. GP prescribing in 4.3.5. These up-to-date, or the most up-to-date figures that we had at the end of June are indicating a projected overspend of 1.35 million for this current financial year. Again, this is actually in line with our financial plan, where we were indicating an overspend this year of about 1.5 million. But it's like the overall position, it is a significant swing from the underspends we've seen over the last few years. A lot of this, as previously noted, is as a result of the anticipated volume and pricing growth that the prescribing aspects have seen, but also includes the inflationary pressures and short supply issues that are evident nationally and internationally as well. And in 4.3.6, it's probably pertinent just to mention, particularly following on from the previous aspect of the primary care report that Shona and David have just presented, 4.3.6, other primary care service overspend predominantly relates to the Dundee's apportioned share of the additional Tayside GP practices that are run under 2C arrangements, where these are run by the health board rather than as independent contractors. So there is a cost pressure aspect of these 2C practices that Dundee takes a share of. A couple of other specific unexpected overspending pressures that are emerging in the current financial year. And 4.3.7, there's quite a significant cost pressure coming through on the Tayside-wide GP out-of-hours service. And as that's a lead partner or what was previously known as hosted service, the Dundee has to take a proportionate share of that. And in 4.4.4, that's a bit of a tongue twister itself, there's a cost pressure emerging in our local care at home externally provided services as well. So in these two sections, there is some comments in there in terms of some of the actions that are currently being explored to address some of these emerging cost pressures. 4.5 just highlights there could well be a legacy impact of the COVID spend from previous years. We no longer are receiving additional funding from Scottish Government for that. Any legacy or ongoing spend that was previously covered by additional funding now needs to be treated as business as usual and managed from existing resources. So any ongoing spend that we previously would have treated as COVID additional expenditure now needs to be managed and reported. So therefore that spend is included in our reported position. 4.6 table 2 just as a note mentions or details our reserves position at the opening position for 23-24, so just highlights where we're actually at with reserves. And as an appendix 4 also just mentions and just summarises and evaluates the savings target proposals that we detailed in our budget paper for 23-24, so it just keeps that back as a reminder and additional information. Happy to pick up any questions if there's any comments or anything from any members.
Yeah, thanks very much for that, Christine. A couple of things for me. The COVID funding that we're not going to receive any more from the Scottish Government, but we're looking at the legacy of COVID. People that maybe have long COVID. I don't know whether it's a scare story or not, but I've seen reports in the last few days that there's apparently a new variant of COVID and that it's already in the UK. And it's not your remit, I guess, to be able to answer that question. Maybe Emma could comment actually. Are we looking at a new variant, and is it likely to cause problems this winter? Yeah, Emma, would you?
Yeah,
you suddenly appeared, so I think I just assumed you were going to comment, but yeah.
Yeah, no, very happy to, and apologies, I was just closing my door. Yes, I mean, we continue to monitor the epidemiology, the infection rate, and the impact of COVID in the community, and that includes any new variants that are circulating. As this pandemic has transitioned into an endemic and it is part of the circulating virus, it will wax and wane. So we are to expect that to some degree. We do not have, there's no indication to say that this variant is causing any more clinical severity of illness or not, but we are just continuing to keep monitoring it. The advice is, if you are unwell, to stay at home. And I just strongly emphasise the general public health messages for any kind of infectious disease. I mean, good hand hygiene, good respiratory hygiene, and if you're eligible for the vaccination and haven't yet already had it, or over the forthcoming autumn-winter campaigns when they come live over the next few weeks, please do take it up. But it's something that we will continue to monitor. But at this point, we're alert to it, but it's not causing undue concern at this stage. Thanks, Ken.
Yeah, thanks. I appreciate that. And the other thing I wanted to comment on was, which is really concerning, is the underspend as a result of being unable to recruit staff to key positions. We heard yesterday afternoon, I was really quite shocked to hear that there's apparently a 40% reduction in those entering nursing degrees to become a nurse. That really shocked me. And I guess you might think that if we were able to recruit to all these positions, then it would make the deficit position worse, but it probably wouldn't, because we're having to pay a lot of locums and agency staff to cover for the vacancies that we can't fill. So that really stood out for me, and it's a real concern. I'll take the questions in the order that I see them, and Raymond, you're up first.
Thanks, Ken. You probably stole my question a wee bit, because I was going to raise the question around, and it's quite concerning that we're seeing most of our underspend is due to vacancies. So what's the impact of that on deliveries of services? And it's that, and it's probably a little question around reporting for yourself, Christine and Dave, around, and I mean, another within the board, NHS board, and finance papers that received through there, we do see tables that outline what that supplementary staffing cost is. So when you look at this tables and you look at the underspend, all you see is an underspend, but you don't see what that's in relation to. So it would maybe be something to consider for the board around understanding, and it would be probably easier to understand that underspend. But I think my question is really, is there a comparison? Is there some work being done around the papers that were previously seen today around all the thumbs down elements compared to those vacancies, and then what work's ongoing then to fill those vacancies? Because I agree with what Ken's saying, and I think it's already been borne out elsewhere, that if you fill the vacancies, your supplementary costs will reduce. You know what I mean? Because you're working within your finance. Either then you've got to adjust the finance bit to say, right, because the question would be, if you never fill X amount of posts year on year, then is there still a need for them? And what you need to adjust is the delivery of your service, and you need to indicate that. So I think there's a suggestion in there and a question, I think. Thanks.
I noticed Jenny's put her hand up. Did you want to come in on this particular point, Jenny?
Yeah, it was just to say there's obviously multifactorial kind of reasons behind this, but there is a number of areas of work that are underway, including the kind of wellbeing work, looking at different terms and conditions and things. Where it will probably all get brought back together is in the workforce plan, and we're intending to bring a review of that back at the next IJB.
Oh, okay, that's imminent then. That's good. Donald?
Thanks, Ken. A question, and it may be me just not being back up to speed on this, but in the financial tables at the back of the paper, we show the split between Dundee City Council delegated services, NHS Tayside delegated services, and there's a single line in the Dundee City Council delegated services for support services management costs that's showing a £3 million overspend. And I just can't get my mind around what that's relating to and why it should be such a high overspend.
As we were developing the financial plan for this year, we've obviously identified where our costs and our budgets and our positions and everything needed to be. So effectively, that is, I think a lot of that becomes effectively our gap that we now need to be filling with our reserves. So that becomes almost a one line of where it is. But I appreciate maybe it's not quite as clear as what it, you know.
It's just maybe
and
not
that's where our reserves
description.
would slot into it. Our investment from our reserves would then slot in to fill that overspend gap. And perhaps Dave's going to explain this a little bit more eloquently than I've just tried to.
Yeah, Dave.
No, I was just going to say in terms of we can look at the format for the next meeting in terms of maybe separating that out from a support management cost, because it's not strictly that. It is, as Christine says, it's actually the fact that by the time when we look at the budget, and if you recall from the budget papers, we had all the various pressures and then some of the funding solutions for that. So there was always going to be a gap in terms of the budget, because we were always going to be £3 million of a gap within that. So it needs to sit somewhere, and it's just where it sits. So it probably needs to be a bit clearer then in terms of where that sits. Because you're right, we're not. I mean, I'm not sitting as a support services manager with a £3 million overspend. That'd be after me telling managers to balance their budgets. It'd be a bit of a cheek for me sitting with £3 million over. But it is about that. It's the format and that. So we will look at that for next time.
Okay, no, that makes sense. Thanks. I think it's just the how we name that line then. Thank you.
So if there are no further questions, that is for noting. Thank you.
That takes us on to item 10, which is the Shakti Women's Aid Outreach Service, and this is for approval.
Okay, so you'll have read the agenda item. This is clearly a very good cause. We wouldn't want this service to stop operating. They're needing some financial support. Dundee City Council has contributed. NHS Tayside, well, the Charities Fund, or whatever it's called, are currently considering the request. And we have been asked, and I'd personally be happy to contribute 15,000. However, Donald very usefully actually brought to my attention. Donald, do you want to maybe say what your concern was?
Yeah, thanks, Chair. I thought it might be best if I posed the question. It's very simply, is this within our authority as an IJB to make a payment like this? Because clearly, we must not act ultra vires.
Sure.
And it's a charitable donation. It seems like a charitable donation in nature rather than us commissioning something. And if you think about the way we are created, our authority as an IJB is just derived from the statute, and so we can do things that are delegated to us by the council and the NHS, and that's in the integration scheme. So we can set strategies, we can commission either body to deliver it, but I would just like to be assured that within our authority is making a charitable donation, because, well, one, because it will set a precedent. That may be a good precedent or a bad precedent, but two, it just takes us into that area of what are our powers as an IJB. So I think it's a really good charity. I've got a couple of questions about it that if we get on to discussing the substance, I would like to be assured on, but I think what they do is invaluable. And I don't want to detract from that, but I do want to be assured that it's within our scope of authority. And I think that's probably a legal question.
Yes, I agree. I agree with you. And I'm wondering if Roger Menny is available to comment on this. Yep, there he is. Hi, Roger.
Thank you, Councillor Lynn. I thought it might be helpful, given that there are some new attendees at the meeting this morning, if I first of all introduced myself. My name's Roger Menny, and I'm the Clerk and Standards Officer to the Dundee City Health and Social Care Integration Joint Board. In that capacity, I act as the Joint Board's Chief Legal Advisor. That's also a role that I carry out for a variety of other organisations. I'm also Chief Legal Advisor to Dundee City Council, Dundee City Licensing Board, Dundee City Licensing Committee, Tayside Valuation Joint Board, Tayside Contracts Joint Committee, the Tay Road Bridge Joint Board, the Tay Cities Region Joint Committee, and also to the Returning Officer for Dundee City. By profession, I'm a solicitor in Scotland, and I've been engaged in public service legal practice for over 36 years. A key aspect of the role that I play in all of these organisations is considering and assuring the bodies to which I advise whether or not proposals are lawful. So turning to the question that has been asked by Mr Macpherson, I have not had cause to consider whether or not the IJB has powers to make charitable donations, so I don't express any concluded view on that this morning. If, however, this proposal is agreed, this will not be in the nature of a charitable donation. It will be in the nature of a contractual relationship with a monitoring process in place to ensure that expected outcomes are delivered in return for the funding. My understanding is that that is also the basis on which Dundee City Council intend to proceed. Clearly, it will be a matter for NHS Tayside, or the body which Mr Macpherson chairs, to take their own legal advice, and I clearly wouldn't seek to interfere in any way with that. But I'd like to assure all members of the Integration Joint Board that I'm satisfied that the proposal that is before the meeting this morning is intra vires, or as it might be more simply put, within the board's powers, and that advice is the advice which I have also given to Dundee City Council in my capacity as monitoring officer. Mr Berry may wish to deal with the other questions that Mr Macpherson raised about other issues, but I would want to assure everybody this morning that I have no concerns whatsoever about the legality of this proposal. If there are, however, any further questions I can assist with, I'll be very glad to do so.
Thank you, Roger. Did you want to add anything, Dave?
I think Roger's probably kind of covered most of that. I think the key thing for us, I mean, I absolutely can understand the question and in terms of whether it's something that we would do, because we wouldn't. I mean, as an IJB, we do not have sort of kind of grant payments. We don't make grants. We've no, kind of even before the IJB, the old social work department did not make grant payments for a long time. Everything is under a contractual arrangement, so that there needs to be sort of outcomes delivered for the investment of public money there. This does fall under the sort of kind of public protection banner, which we kind of host on behalf of kind of Dundee City Council. So it's kind of something that, from as far as we can see, is kind of very relevant to that agenda. So and the reason that I'm suggesting that it comes from the IJB reserves is, of course, we don't actually have a budgeted provision, so we've not made any budgeted provision within our budget setting for this this particular aspect. So, but again, happy to take any more questions on the proposal itself.
I'm just wondering what was mentioned about precedent. Would we be likely to see more applications against our reserves from other bodies?
But I mean, again, it would be, you know, if there were issues that organisation of funding that organisations wanted to approach us around, then no, we would consider that. But again, it would have to be something that's in line with the delivery of the IJB's strategic priorities and objectives, and also it would always kind of come through a route of through sort of kind of a commissioning side of things. So, you know, in this instance, it's kind of going through the Dundee Chief Officers Group, the protecting people kind of side of things. So It's not a kind of almost like a random, somebody's just written in and asked for money. There is a kind of route to that.
Okay,
That's what
yeah,
we'd be
yeah.
looking for in terms of anything else that would come forward.
Can I bring Roger Many back in, please?
Thanks again, Councillor Lynn. Just to confirm from my perspective that if the board were minded to agree to this proposal this morning, it would certainly not set any precedent for the future. And as Mr Berry has indicated, all other considerations will be available to the board if and when matters are brought before the committee in the future. Or put another way, we could agree to this morning, but we could refuse future applications or future arrangements if that was thought fit.
Okay, thanks for that. Raymond?
So I sit on the same committees as Donald in relation to endowments and charitable funds and stuff like that. So I do have a concern that, and I can understand what Roger's saying about precedent, but it could set up, I think it could set a precedent because people could say, well, actually, that's somewhere I can go then to ask for monies. My concern is that we do not have a fund. We do not have an actual fund to allocate. So which services, and I'm asking Dave, so which services are not going to receive £15,000 because you contribute to this? Okay, I'm not you, sorry, you personally, Dave, right? If we didn't have reserves, right, where would the 15k come from? You know what I mean? I think it's correct for as a board, and I know that I'm a non-voting member, but I think as a board that we signpost these people to the appropriate elements to get that, and that is to go to the Charitable Funds Committee and look for these kind of things to support that. I'm pretty sure the Dundee City Council has similar avenues from that. I don't know how the council operate their budget, but there's not a budget in here to allocate funds on a one-off. And I think it could be set a precedent where people could come along and say, oh, so if you gave it to this, then why can't you give it to me? I'm giving you the same application. What is the application process? What is the criteria that you set for approval? What is the you know what I mean? So there's lots of things that sit here that says, right, so how do you set that criteria of approval? I agree with everybody else. I think it's well worth, and hopefully it will get support elsewhere. But to me, we don't have a criteria. We do not have a governance around this in relation to approving applications like this. So I do have a concern. Thanks, Chair.
Can I come back on that? Yeah, so Raymond, yeah, you're absolutely right. I mean, we do not have a budget for it, which is why I'm asking the IJB to look at the reserves that they have to allocate some of the funding for that. We do have about £10.7 million of unallocated reserves. We will put something at the next IJB about proposals around spend against that. But given the scale of the ask that's coming through, the £15,000, there's no direct impact on any sort of service delivery if the board was kind of minded to support that. In terms of process, yeah, because as I said, we don't have a grant application process. We're not planning on doing that. It will be around any other asks that if anybody comes forward, but it has to go through a particular sort of strategic planning group. This one in particular has gone through the kind of public, so the Protecting People strategic group. They have assessed that they have kind of decided that from their perspective, it is something that is within, it's aligned to the objectives and priorities, and have kind of then put a recommendation back to the partner bodies, so council, ourselves, and NHS Tayside, that this is something that they feel is worthwhile. It's contributing to local service delivery. It's kind of certainly contributing to kind of keeping people safe. Therefore, there is an absolutely kind of very clear kind of outcome and objective, which is why we will be wrapping a contract monitoring sort of process around it. So it isn't just here's 15,000 off you go. It's here's 15,000 plus Dundee City Council's 15,000. let's say, the kind of outcomes that you deliver for that. So so it wouldn't be our intention to kind of set up a different infrastructure for people to kind of come forward. But if there are things that come through, they would be signposted to the particular strategic planning group. So if it's something around learning disabilities, mental health, substance use, etc., they would all go through those particular routes. And then if supported, then a recommendation would come through to the IJB, and we would obviously need to look at any funding sources around that.
Raymond, do you have another question, or do you want to respond to that?
I was just really to come back. Thanks so much, Ken. I was just really to come back, Dave. But if you did not have the reserves, would you be considering the applicant? You've got to go back onto, you have to allocate a budget to this. You can't just say, because we've got the money, we'll give it, and because it's and I'm sorry to say, because it's a worthy and good cause, that we will give money. It has to sit within a criteria, and because another service or another committee says it's a good cause, it's whether it's within, and whether we have the budget and it sits there as because another application will come along, someone else will say, right, well, you gave this, so where's the budget for it? Thanks, Ken.
Yeah, I think they applied though, did they, Dave? It came through the Protecting People group. There was a kind of recommendation from them. They didn't. Maybe they did approach someone. I don't know. Diane, were you wanting to add something else to what Dave said?
Thank you, Ken. Thanks very much. I sit on this group as the Chief Social Work Officer in my as that role, as well as Head of Service, and I suspect I probably don't come in an awful lot as Chief Social Work Officer because it's part of our day-to-day business, but I would like in that role to speak on behalf of this. So I absolutely understand the board members' concerns about the process, and equally about the pressures that we have in our system and how we might or might not want to utilise any resources that are available to us. What I would say though is that we are seeing an increase in the number of referrals under public protection, both in relation to adults in the community, child protection, but also in relation to people from a different cultural environment. We also have a large number of people who have come forward in relation to being arriving in Dundee, both either through asylum seekers processes or Ukrainian people coming into the city. So we're seeing a change in the nature of the people that we work with, and we're seeing an increase in the acuity in terms of some of the areas of work that we're having to support around adult support and protection, violence against women, and other kind of public protection programmes. I think if we don't support this organisation to get through the next period, we're looking at an issue in the city and how we actually then continue to support the people who are coming through that route and actually being able to do them. And for me, what that will do is put additional pressures onto our services in terms of our public protection processes and resources. So I think we have to look at it not just as it being a worthy organisation, but an organisation which is supporting some of our key processes. And it's my intention over the next few months to actually really look at how we're supporting our public protection work and what it is that we're thinking about doing. Probably also worth mentioning right at this particular point in time that we've just been notified that we will be having an adult support and protection inspection coming up in the next short while. It's been a very sudden notification, literally in the last 24 hours or 48 hours, and we need to be able to get through this next period with the resources that we need in order to continue to support that. So as Chief Social Work Officer, I would be suggesting that in this situation, for this amount of money, given that we're talking about a bridging resource to allow the organisation to seek additional funding, but also to consider what therefore might be that longer term funding and how we might support it, I would be asking the board members to support. Thank you, Ken.
You certainly convinced me. Now I'm going to allow 3 more and then we'll wrap this up. Siobhan, followed by Donald, followed by Dorothy. So Siobhan.
I think Donald was first, but
he was, but Donald's spoken quite a lot this morning, so I thought.
Okay, fair enough, thank you.
No offence, Donald. It just.
No, thank you.
None taken.
I get the procedural issues or the concerns. I get the precedence concerns as well, but we're talking about a very vulnerable group of already marginalised women, and I do think that we cannot divorce the morality off this from the procedure. Diane, I'm echoing absolutely everything you said. To be honest, it's not just a case that we've got the case of it will help us prevent further problems down the line, but what we're actually talking about here is trying to prevent an absolutely essential service for, again, marginalised, abused women from fragmenting, and that is absolutely vital. Now, we can deal with the precedents at another time. You know, we deal with cases as they come along, but to say no to this, it feels very, very uncomfortable for me. I get the precedents, I get the kind of procedural process, but as Roger said, he doesn't have any concerns over this. We can find the budget, we clearly can. It's not that much in the big scheme of things. And I'm going to say, if there's anybody sitting on the fence here, I'm kind of going to make a bit of a passionate plea here. If there's anybody sitting on the fence, let's err on the side of caution and support vulnerable, marginalised women. It's £15,000.
Thank you. Donald?
Yeah, thanks. First, I mean, I take assurance from Roger's comments, and I think one of the things that didn't come across from what's admittedly a short note in the agenda was that key point about there will be a contract, there will be deliverables on the back of this. So and I accept, I portrayed it as a charitable donation, which was what I read it as. Clearly, that's not the case. And, commissioning services is certainly within our remit. I think the question that it prompts for me is, why is Dundee IJB, or the Health and Social Care Partnership, not actually commissioning the whole 45,000? Because it's the role of this group to provide these sorts of services within Dundee itself. So I think that perhaps the involvement of City Council and the NHS Tayside and the charity confuses matters slightly. I take Roger's point. He's not going to advise Tayside Health Fund. That's a matter for us, absolutely. But it almost would put me the other way, that shouldn't actually the IJB, as the relevant body, be the one that's picking up the whole tab on this. Other than that, I mean, Siobhan, to be clear, I'm certainly not on the fence or against us supporting this. I think it's important that we find the right and the appropriate mechanism. And the only remaining question I had was, are we clear as to why the previous funding that the organisation had is no longer available? And are we clear that this is really a one-off, rather than, will we get the same ask this time next year? So these are my points. Thanks.
Catherine, would you like to come in at this point?
Yeah, I can respond to Donald's questions there. So in terms of the previous funding, it's a situation where national funds have been used to support it, but as you'll be aware, there's a number of national funders who will kind of fund projects in a maximum length of time, and then they expect that a mainstreaming approach will be taken, and that normally local public sector services will take on the kind of financial liabilities around services if there's a continued need for them. So that's the position we find ourselves in relation to this project. The Chief Officers Group collaboratively have had been managing the risk around about this service for a significant amount of time, and looked at sort of various different aspects of funding, but that is why that's come to the end. And remind me, Donald, of the second part of your question.
It was more about why we're not just funding the whole thing through the IJB.
Oh, why that won't come back as well. So that the kind of you've asked about, will we not just get this back? I think we've been very clear in discussions with Shakti that at the moment there is no identified resource to be able to make a longer term funding commitment, and that the funding, if it is provided on the basis that will give them some time and breathing space to look at alternatives, including revisiting some discussions with the Scottish Government in light of a recent national funding review around violence against women's services that made some recommendations around services for Black and minority ethnic women in particular. But we have been quite clear that they cannot rely on making a further bid to the IJB or the council or anybody else, and any contractual relationships that will also be made very clear in terms of the contract. The Violence Against Women Partnership is managing this as one of their strategic risks on their risk register, so they will continue to provide support to Shakti in terms of their search for further funds, but they are also clear on the parameters of any award as non-recurring.
Okay, thanks.
Thank you. I have huge sympathy for this request, but in my role on this board, I'm trying to resist emotional pressures. I'm going back to Raymond's question. If we didn't have reserves, would we be considering this? And the answer, I think, is no. The reserves provide a level of comfort for future eventualities, and any monies from our budget should be allocated according to our strategic plan. And if something like this, is needed, it should be part of our strategic plan. At the end of the day, I'll go along with the majority here, but I do have concerns that I don't know if if this is our role, if this should have come to us. I do have huge sympathies, Siobhan, but in my role as a member of this board, I do have concerns about a payment like this.
Catherine.
I mean, I suppose at a high level, Councillor McHugh, I can assure you that the project aligns well with the strategic priorities. We wouldn't be making a request from IJB if it didn't, broadly in terms of health inequalities and the accessibility aspects, in terms of the open doors priority, and also the last one around working together. There's a number of strategic shifts in there that are around identifying and supporting people at risk, improving access and earlier intervention around about that, and addressing inequalities around about that too. So I would be happy for any members that want to further assurance outside the meeting to set that out in a little more detail. But the conversation that's taken place over a number of months at Chief Officers, and just to remind and reassure everybody that this has not been an immediate ask. There has been a lot of discussion around managing the risk associated with the service, as Diane described, and looking at all other possible sources of funding before asks have been made to the Council, NHS and the IJB as well. So I can set that out in more detail, but at a high level, this is absolutely aligned to the strategic priorities that the board recently set for itself.
Okay, definitely the last speaker. Raymond, I'll allow you back in once more.
Thanks very much, Ken. I mean, can I be just very clear? Like, I fully support what this work's done. So this is not about the work that's done and the intention. I agree that it fully meets what the IJB is about and what we're trying to deliver across the city. So that's not. This is about process. I've sat in this IJB from its inception. We have never had an application come in to the IJB like this. We have never dealt with this. Right, there's not, so this is the first time it's come in. So that's where the questioning is around, is it appropriate to come here? I think there's other mechanisms, and I agree with what like Donald was saying there, is that if this was meeting all the strategies and it was something that you wished to commission, then you would pay for the lot. That's a different process. This is about someone coming and saying, can you give me part off to fund something? Okay. So I'm just saying, I don't get a shot on this, because it's up to the board members, the voting members, so it's up to them. I'm just saying we need to be very mindful of that this is the very first application that's came in here. The principles and the direction I totally agree with, and it should be funded from somewhere. But is it within, and I know what Roger's saying around that, it sits within that. This is the first time anything else has come to the board. We've never been asked for money at this board like in this way. Thanks, Ken.
Raymond, your opinion and voice is just as valid as any of the voting members. It's just that the current system that we have imposed on us almost is that there are only 6 voting members. However, you're able not only to speak but to propose a motion if you have a seconder, which would then be voted on. So just to make that clear, I think this is an absolutely unique service, given that it supports Black and minority ethnic women. And after all, this is just a bridging loan, and I do agree that they and we need to look at more long-term sustainable funding, whether that comes from, because Dundee City Council, every year when we're trying to formulate the budget, there are dozens of groups that the council gets money from. And I suspect Shakti should be one of them, given the unique nature of the service. But where we are just now is they're going to fold unless they get the 15k from us to supplement the 30k that they're getting from elsewhere. I do think we would need to change the wording a little bit on the agenda note to make it clear that there's a contractual relationship and that outcomes will be monitored. Where can we insert that, and what would the wording be? Just maybe what I said. Right at the end, is asked to approve. This will establish a contractual relation. No, Roger. Yeah, your view would be helpful.
Thanks very much, Councillor Lynn. Can I suggest that matters be remitted to Dave Berry, Vicky Irons and myself to prepare a form of words which will eventually form part of the minute? I think we all absolutely hear and understand the points that have been made by all members who've spoken in the debate this morning. And I would want to give everybody an assurance before you make your final decision that I am absolutely satisfied that this falls within the board's powers to decide if that's what they wish to do, that it sets no precedent, and that there will be outcomes delivered in return for this funding, which has been indicated by other speakers are absolutely in line with strategic priorities that the board has set itself.
But what I'm saying, if that wording isn't in there when we make the decision, though, isn't that quite important that the wording is actually there? I mean, if you add it afterwards, we've agreed to give them money without any mention of a contractual relationship and monitoring of outcomes. I don't see how you can add it after. That's what I don't understand.
Well, we wouldn't be adding it afterwards, Chair. What we're saying is that the officers have indicated this morning that this will be in the nature of a contractual relationship, that there will be a monitoring process, and that outcomes are expected in return for the funding.
Yeah, that's great.
And all those points will be mentioned within the minute. Clearly, however, the approval of the minute is a matter for the board, and when it comes up the next time, I hope that it'll meet with everyone's approval. But as I say, it will contain those three elements, which to me distinguish it entirely from a charitable donation.
Okay, so I am certainly in favour, for all the reasons that have been expressed and ones that I've expressed as well, for going ahead with this. And this is what we always say at the council when there are contrary opinions: is anyone else minded? Is anyone otherwise minded? And if they are, we could go to a vote. So is anyone otherwise minded? I don't see any indication from anywhere. So thanks for that. That's approved.
Thanks. That takes us on to item 11, which is the attendances from the meetings, and it's submitted for information only.
Okay. Well, thanks everyone for your attendance. I'll see some of you at the park, and the rest of you I'll see in 2 months' time. Okay, thank you for your attendance. Bye.
Thank you.
Bye, bye.
Thanks, bye.
Bye.